So thank you all. Pleasure to be here. Michael and I were talking backstage, and this was my idea, not your idea. So it's my job then to introduce you. Thank you for doing this. And
great to be here.
Yeah, and we thought that it would be interesting to talk about technology and healthcare, and also Michael's interest in healthcare. And so maybe I thought we might start there. So you actually have a long history of interest in healthcare, so dating back to your childhood. So tell us a little bit about that.
I do. Well, my father was a doctor, my brother's a doctor, all my cousins are doctors, and I was supposed to be a doctor. So when I was in my dorm room, starting a computer company, I was supposed to be studying, pre-med, but that didn't work out so well. And
or maybe it worked out better for you to drop your pre-med.
Yeah, well, the doctor part didn't work out.
The doctor part.
But we started the company, and about 20 years ago, we set up a foundation, and my wife and I, Austin's our home. This has been a great place for us, and we've been really interested in how we could develop the health of the community and do things around the world. So there was a need for a children's hospital in Austin, and or a new children's hospital. There was already a children's hospital, but there needed to be the city was growing tremendously. So back in 2004, we helped with that, and that led to a Pediatric Research Institute, and that led to a Center for Healthy Living, and a lot of those were kind of the foundations that ultimately led to the medical school that you're now leading, and the teaching hospital, and Del Seaton Medical Center. And look, I think healthcare is an area that is ripe for innovation. We all know there are challenges in the system, and it's a super fascinating area.
Yeah, well, I mean, it sounds like you started out by saying, gosh, we need a great healthcare system, we need a great health system too, because you all have been focused on health in the communities, not just what happens in clinics and hospitals as a start. But now when you look at where things have gone, in your interest in making it more innovative, I mean, how have you seen that evolution?
Well, I think if you step back and you look at the healthcare system, there are some pretty alarming bits of data, right? The percent of the GDP, the number of people employed, the outcomes, and there's a lot of discussion about value versus volume and outcomes that you've been leading a lot of thought on that. I'd love to hear you talk about those areas.
Well, yeah, and happy to, and your perspective too as a large business owner too, thinking about purchasing this stuff. But to me it's pretty incredible. So we're almost up to 20% of GDP, and in some ways that doesn't feel so bad. I mean, health is so important. Shouldn't we spend 20% of our dollars on it? On the other hand, when you compare us to other countries, it's substantially greater than other countries in terms of percentage of GDP or in terms of absolute dollars. So the next closest is either Norway or Switzerland. We're 30% above that. And our health outcomes are nowhere near what they are in Switzerland and Norway. And in fact, the UK has substantially better health outcomes than us, and they spend about a third of what we do. And in fact, you live longer in Cuba than you do in the US, and we spend an average of $10,000 now, just about close to $10,000 per person. They spend about $800 a person. So complete disconnect between what we pay and what we get out of the system, and clearly a system that's gone awry. A system that should be the absolute best in the world and yet is not.
Yeah, and those countries certainly aren't using AI or data, in a way that as I think about all sectors of the economy in the world, there is a big change going on, right? With the enormous explosion in the amount of data, advances in computer science and, computing power, bandwidth, Internet of Things, et cetera, all this data, there are profound opportunities to change outcomes. And if you think about activities in the world along a spectrum from, something that is completely handcrafted, one at a time, one-to-one, every single time is different, right? To, it's heavily assisted by all the collective intelligence and all the data and experience. There's 7 billion people in the world. If somebody presents themselves, with a medical condition, what's the chance that that's never happened before?
Yeah. Well, pretty much close to zero.
Yeah, and so how often is your doctor using data and information to be able to better diagnose and solve that problem?
Yeah, it's a great question. I mean, obviously there's some barriers that just relate to the way docs are paid, right? So you're paid for the encounter with the patient, regardless of whether that leads to a positive outcome for patients or not.
Right.
And technologies, if they make things more efficient, often take dollars out of doctors' pockets. And so there's a tendency to resist those things in a fee-for-service system. And obviously, you hear me talk about all the time, we need to move to outcomes, improving outcomes for patients and actually paying for better outcomes. And then technologies can have a role, and it's not just about what doctors can do. And in many ways, it can liberate what doctors do.
Yeah. So why don't you share, with the folks here, what has been the approach and philosophy in creating the new, Dell Medical School?
Well, it's interesting because I think we didn't purposefully take a page from your playbook, but I think we are doing a lot of things that you had done early on in thinking about Dell Computer. I haven't tested this out on you, so you can just tell me no, I'm way off. But no, obviously you all were focused on democratization of technology.
Yes.
And you were highly focused on the consumer. How do you create products that consumers want? And obviously they don't want to pay more than they have to, and they want that technology to do more and more, to do the things that are important to them. Well, we don't have a similar approach in healthcare currently. If you think about the consumer experience in healthcare, even the experience at the DMV is more favorable than it is in a doctor's office today. At least the Texas DMV. The California DMV, where I came from before, I'm not so sure. But in the Texas DMV, you at least you type in your cell phone number and it tells you when you'll be up. It gives you some realistic. But in the average doctor's office, you're waiting 40 minutes. That's the average wait time in a doctor's office. Complete disrespect for people. But that's only a minor thing, but it's emblematic of what's going on more broadly in the healthcare system. No one really wants to be a patient. No one wants to go to see a doctor in the clinic. Very few people do. No one wants to be in the hospital. What we want is health, right? We want to be healthy. And the system ought to reward us achieving health. Like it rewards, if it's a good movie and it entertains us, then people go to see the movie. We don't have any measurement, just as you say, there's no data that's shared about what are those outcomes. And we don't have a system in place that rewards that at all. So the economics of healthcare about the delivery of more healthcare, not the delivery of better outcomes.
Volume versus value and outcomes.
Exactly. And volume, that we do well in the U.S. We generate a ton of healthcare in the U.S.
That's how we got to 20% of GDP.
That's how we get to 20% of GDP. But it doesn't actually improve outcomes. It churns and produces costs, but not outcomes. So what we're trying to do is focus, just as you did, on the customer and on people and what people want, and then design the care around what those people want. And that should include technologies. I mean, we have even trouble today integrating email into care of patients. What does it mean to really bake in technologies in how we care for folks as well? Disciplined on outcomes, and then trying to get paid by purchasers for the outcomes, not for more care. And we've got some models that are underway. The key then becomes dissemination for us, which I think we're also, that's a page from your playbook that we probably can't completely copy, but we're going to have to figure out some disruptive way to disseminate.
Yeah, but you're starting to figure out how to share your learnings with other health systems, and the approach that you're taking to community care here in Central Texas. I think one of the really exciting things, of course, is that you have an opportunity to reinvent and change things, and the community's been very supportive of that.
And that's terrific. So uniquely, we are supported by the community. They voted to increase the property tax to bring the med school here, and that provides substantial support, links us to the community in a great way, and then it makes it more natural. We do actually have incentives aligned to produce those better outcomes, and that's our county safety net system for Travis County, the County of Austin, and those are fixed dollars, relatively fixed, and more need than can be delivered in a traditional U.S. healthcare approach for those dollars. And they've been wonderful as partners to think, okay, well, let's just do it the right way instead of the way we would traditionally do it, and see if we can make the dollars flow appropriately to reward the value that's being produced. So yeah, that's absolutely right. So as you mentioned, the first one that we tested was in joint pain. So it ends up being one of the most expensive things in the U.S. healthcare system. The most expensive thing for Medicare or Medicaid right now is joint pain, mostly from joint replacement surgeries. And we completely redesigned that care. And we think of it as a product, the treatment of patients with joint pain. It looks really different. It feels really different, and patients like it better. And now we know, after doing it for more than a year, the outcomes are better and it costs less. So we can do it for actually substantially less than the traditional cost. So that's an example of that. Data is absolutely critical to making that work. Feeding data back in, collecting that data, and putting patient-reported outcomes, just as you mentioned before. Yeah, and you all are seeing this already. Dell's been big into healthcare data for a long time. And how do you see that? Is it continuing on in an explosion? How do you see that evolving?
Yeah, well, if you think about the kind of plot of organizations today, there is this cycle that companies and organizations use, where they kind of start with some data. Maybe they have a little bit, maybe they have a lot, and they take that data and they use it to create a better product or a better service in some way. At least that's the idea, right? And when they do that, they bring it to their customers, their users, their community, whoever it is. And if they're successful, they get more customers, right? And then they get more data, right? And then the cycle just repeats itself. And the faster you can speed that up and make improvements to your product and your service, the better you'll do, and the better outcomes, better results, the more your company will grow, et cetera. Now what's really interesting is, in between this data and the improved products and services, there is this explosion in new computer science, right? With the artificial intelligence, the neural networks, the deep learning, and the computing power, and the number of connected devices that are generating this data is also exploding. So everything's becoming intelligent. So you have this kind of intelligence of connected things, and a collective intelligence, and whole things just going at an incredibly faster pace. So this necessitates a need to kind of reimagine what you've been doing, because if you've been doing something for, let's say, like 100 years the same way, right?
Right.
Which
we have in healthcare in many ways.
And in education too, right?
Yep,
so
education too.
You got both opportunities. Yep. How do you then reimagine it to say, wow, we have all these new tools and capabilities, how can we begin to do something completely different here?
Right.
And better? And take on risks and innovate.
Yeah, and, it's fascinating that, that has happened just as you described in pretty much every industry. Healthcare has been slow. It's probably just because it's so, regionally and locally focused in part, and probably too because actually the industry hasn't really competed on quality, either quality of the patient experience or quality of outcomes. There's perception of quality, there's referral networks and all that occur, but there's not really the same accountability for quality, the measurement and comparisons and all that exists in many other industries.
But I think it has to go there, right? And so how do you train, the doctors of tomorrow for a world of AI and machine learning? And
yeah, we've been thinking a lot about this. So AI definitely is not just a pipe dream anymore. It's interesting, you go back into the medical literature and you see articles about AI from the 1980s, and how computers were going to change medicine and all this, and they barely touched it other than to be a huge annoyance in healthcare today. The thing that physicians rate as their greatest detractor from satisfaction in practice is the electronic health record. Amazing. It should never be that way. It will, and eventually we'll figure this one out. But it has been a detraction. But in the future, now we're starting to see already AI doing things that physicians can do, and doing them at least as well and faster and cheaper. And we will quickly see them doing it better. So reading chest X-rays. For specific kinds of findings like tuberculosis, they do it just as well. Finding cancerous cells in pathology slides, another example where AI can do that better. And now even making diagnoses more accurately. And it is true too, just the low-hanging fruit stuff, we haven't let the systems do this. High blood pressure. It's incredibly common, like more than half of adults have high blood pressure in the US, and we still have only about a third of people with high blood pressure adequately treated. We have a gazillion very safe and effective drugs for high blood pressure that are super cheap, and yet we can't get that group of folks treated. So data and feeding that back and using that and making sure the incentives are aligned with achieving that is going to be important for driving this. And then I didn't answer your question. Well, how does that make us think about the future of medicine? And then I wanted to ask you about bigger issues around AI. But if more and more of what the physician has done previously is doable by AI, then our take is that the way we train physicians is not today doesn't make sense, and actually already it doesn't make sense. So we still are too focused on memorization. When I was in medical school, mostly it was about memorizing stuff and regurgitating it for tests, and many of those things I never used in practice. And nowadays, with quick access to information that's more reliable than memory, and the reality that most of the things that one does as a clinician, one knows so well, you just have to know what you don't know and know how to find it. And now you can do that so easily on a cell phone. That memorization really is not that useful anymore in medicine. And complex diagnosis, understanding data, understanding where to find it, all of that stuff's critical. But then also that gives us more time for physicians to do what they've always done, which is the humanistic aspects of medicine, how they communicate, how they understand, gather information from patients, do a physical exam that has meaning, not just collecting data, but has meaning
context and
the context also, yes, individualizing decision making. And also consoling and counseling patients. All those are really critical functions. And in fact, as we've studied them more and more, we've discovered that many of those things are more important than surgical skills or choice of drug. That the emotional state of patients really does determine outcomes in healthcare. So now, if we can take away some of that distraction or have other machines that do those things better, move those activities, then the focus should be more on the humanistic aspects of medicine, and then our training ought to reflect that.
Yeah, I think there are all sorts of scary scenarios that have been painted, in movies about the robo-apocalypse and horrible things happening in the future. But actually, the outcomes, as it relates to technology, have been broadly, enormously positive. And I'm very optimistic that in healthcare, technology will assist the doctor, the caregiver, in, creating a much better outcome and result. I think the answer here is human plus machine.
Yeah.
Right. Not machine minus human.
Yeah, I agree. Yeah, I mean, I think that's got to be maybe there's some day when machines are as empathic and can connect to humans as well as humans can, but that day certainly isn't going to be in my lifetime.
Well, in there, machines are different than organisms, right? And that's a whole nother subject. But. Yeah.
Well, you and I were talking more generally backstage about AI and how it'll roll out, and I think some of the things we just talked about that's just going to happen, right? I mean, more and more of those tasks that are done by folks in the healthcare system will be taken over by machines. But then, how does AI itself evolve? So, one conceptualization would be that AI is basically one giant brain. You got the internet's actually so well connected. There's one giant brain. And as you pointed out backstage, we're a long way away from that. We have AI that deals with specific problems, self-driving cars or reading X-rays and all that. But there is commonality between those things at a very high level. there's concepts in geology and in weather relate to blood flow and the way the brain works. And so there is some combination of all that. So is it one brain but the problem of course with one brain is if it gets things wrong, it doesn't know, it doesn't see that. I mean, or is it multiple?
And how do we know how it actually calculates it?
Right.
It's so complicated we don't even know. But I think for the foreseeable future, we're going to have specific AIs because the data domains and the fields are so different in terms of what is actually happening with the data. To get a general AI that is all-knowing in all fields and that sort of thing, I think we're quite a ways away from that. I mean, when you listen to the AI researchers and you kind of ask that question, you'll get a range of answers. Mm-hmm. Some of them will say it's 20 years away for a really a powerful generalized AI. Some will say it's 100 years away. Mm-hmm. So nobody really knows. I mean, what we do know is the improvements are coming at a very, very fast pace, and it's definitely a kind of defining moment in terms of the future of all industries and society.
Yeah. In about 9 minutes, we're going to take questions and answers from the Slido system. So if you all have questions, please feel free to use that system. I forgot to mention that at the beginning. And then how do you see, obviously we've seen a big shift of things to the cloud. How do you see this playing out in AI? Is this going to be, obviously sensors and actuators will be close to where they're needed. So in the case of healthcare, on the body or close by. But will some of that computing must sit locally like that and not just in the cloud. So how is that going to evolve? Any insights yet into?
Yeah, what we see emerging is there's sort of the edge computing, which mm-hmm. is all of the intelligent devices. So if you look around, you see anything that has electricity in it, it is either intelligent or it's becoming intelligent. So, there were over 100 billion microprocessors sold last year.
100 billion.
7 billion people, 100 billion microprocessors. Now, most of them aren't actually connected to anything, but increasingly they're getting connected. When you go to the 5th generation, wireless networks, the rate of connection and the cost, the amount of data, it's like 1,000x. And if you think about any sort of a building, a city, a home, a car, every device, just tons and tons of data. And we're seeing this with all of our customers, and they're putting these sensors in every single thing they're doing and trying to figure out how in real time can they use this data to make a better experience, improve the outcome, et cetera. So you have this kind of edge computing, you have a kind of distributed core, which is to say that you're not going to have 1,000 or 10,000 sensors in a building going to the cloud. You'll have a distributed core that will talk to those. If your robots are whizzing around in your hospital, doing things, or in a factory or in a store, they're going to be controlled by some local intelligence that may filter some of that data and then send it back to a cloud. And then you have the cloud, which is has multiple forms. Cloud is actually not a place; it's kind of a way of doing IT. So you can have an on-premise private cloud, which is still very important for a lot of organizations. You can have a public cloud, software as a service, managed services, and so these will all be connected together. Increasingly, there is a decentralization of data and connections as necessitated by the Internet of Things and all these things becoming intelligent.
Yeah, and I'm curious at how you all. So you're just involved in all of those things, and meet the needs of the customers as the needs of the customers grow. You don't have to anticipate necessarily how these trends will occur over time.
Well, we're fortunate to serve most of the largest companies in the world, maybe 99% of them, and a lot of small and medium-sized companies too, and consumers as well. And so we're learning a lot from their requirements, and certainly we're playing a lot in the infrastructure. But one of the things that we see going on is, if you went to a company 10 years ago and you said, "Hey, what's technology?" They would say, "That's the IT department." What do they do? Well, they implement the system and they make the printers work and that kind of stuff. Well, if you go to a company today and you say, "What's technology?" Well, that's actually how we make our products and our services better. That's how we interact with our customers. That's kind of everything that we do is about technology.
Right.
And this is happening in like all companies. So there's been a sort of reconception of how people are thinking about the role of technology in every single organization. And so we are helping our customers that, because that requires new tools. So we see kind of 4 big transformations going on. There's like a digital transformation, there's the transformation of the IT itself, there's a transformation of the workforce, and then of course security, right? As you connect everything together, the attack surface becomes much, much bigger. And if it's running our water supply and food and air traffic control and health and everything, it has to be secure. So we're with our customers thinking about all those things.
Yeah, got it. Good. So Ted, let's go back to philanthropy. So you've obviously done a huge amount on the business side, and now you have done already too a huge amount on the philanthropic side. So how do you think about it? I mean, as you mentioned, you started out by saying we want to make Austin a great place, and how has your thinking evolved about the impact that you can have?
Well, we kind of set a big goal for ourselves to say, my wife and I, how could we have a greater impact in the world with our philanthropy than we've had with Dell the company, and I'll say that's a pretty big challenge, but why not? So actually last year we published something called the Philanthropist's Guide to the Future, and we took a lot of the lessons that we've learned. We've done about 3,000 projects through our foundation over the last 20 years, roughly $1.5 billion invested, and we learned a few things, right? So, first lesson we learned was all about risk and innovation, and you got to be willing to take the risks that the challenge, deserves. And I've learned in business that risk and innovation totally go together. So, if you want innovation, you have to be willing to make mistakes, take some risk, learn, fail fast, and you've taken some new approaches with like team-based care.
Yep. Yeah. So a bunch. So team-based care is a good example. I mean, that example that I gave before about the joint pain is entirely different. So it's people have thought about the surgery, but not about joint pain and how to prevent people from getting surgery. And that's not, people don't want to have a surgery that they don't need. So that takes a whole re-envisioning. And in that care, you're right, that's a good example of that, of riskiness. So there's a bunch of stuff that normally doesn't get paid for. The technologies generally don't get paid for. And then we also have, physical therapists, dietitians, counselors, working with folks, and both before and if they have surgery after. That stuff generally doesn't get paid for in the healthcare system, but we knew it was right for patients, and so we built that into that care model. And that's a big risk because in fee-for-service, in the way we get paid today, we actually don't make any money on that. And it would be easy for us to make money by doing it the traditional way. Send them to the orthopedic surgeon, do a bunch of surgeries. That's a great way to make money. That's why this is a huge...
That's how we got here.
Yeah, that's how we got here. So that is a huge risk for us to do it that way. And what we're doing is we've said this is a better product. And you as a purchaser of healthcare, you want better products for your people. Your people really want them too. Now, how we direct them to it, we haven't completely solved that. People don't know that there are better solutions out there, and they're not currently sensitive to waste, to price. And you are as their purchaser, but they aren't individually. So how do we change that? And then how do we get paid for the value we produce? So you get, and selling computers, if you build a nicer computer, you get to charge more money for it. We build a better product, we get paid the same amount, in fact a little less, and even though our product costs more to deliver, and the outcomes are substantially better than they would otherwise be. That's a risk too. Initially the insurers tell us, this is too hard, we don't know how to do it, we never paid anybody this way before, and we've worked around that by actually going to purchasers. We haven't talked to your folks about this, but we've worked with other self-insured businesses and governmental entities that provide coverage. And then they've forced the insurers to the table to say, you guys figure this out. Because the insurers actually aren't in.
But I mean, the track you're on, I think, has to be a big part of the answer. And there does seem to be a wave across the country of, the things you're doing and other similar things. Porter and Kaplan, at Harvard have been talking a lot about this.
Yeah,
in terms
Elizabeth
of
Teisberg at Dell Med too.
Yep.
Part of that group.
So there's a big movement there. Second lesson for us is around measurement and mindfully measuring, and that sort of goes to this whole area of value and outcomes, and how do you make sure you're measuring the right things? And
exactly. So for us, we measure, we focus a lot on patient-reported outcomes. So first of all, docs aren't really that attuned to what patients want. Patients understand what they want, and we get it wrong. And so going to patients, understanding what their needs are, and then designing outcomes that they then report back to us. So are they pain-free and able to do what they need to do to live a normal life? That's the sort of encapsulation of what people care about, for example, almost in everything. But in joint pain, and so then we can measure that and we can track it and just, as you say, quickly change our systems to optimize it.
Yeah, the third lesson for us is with all these projects that we've done, not all of them worked, right?
Right.
So when something doesn't work, we share that as well, right?
Yeah.
Because it's important to share the lessons. And I know the last few days there was the South by Southwest EDU, right? And so we had a bunch of our teams from the foundation here sharing experiences with educators that came together. There's a lot of people innovating and experimenting together, and we can all move forward by taking the collective lessons faster.
Great. Yeah, I completely agree. So we do that through presentations and publications as well. And those are important for the failures, but unfortunately the publications and presentations haven't changed the healthcare system. There's a lot of stuff that we know we should do that we don't do. I mentioned hypertension previously. A lot of the work in prevention hasn't actually caught on, even though there are many publications about how to do this stuff better. So we do believe, in addition, that we need to figure out a different kind of dissemination model, in that it's going to be disruptive companies moving into into this healthcare market and into other healthcare markets that ultimately produce the changes that we need in healthcare.
The fourth lesson is really around root cause. If it looks easy, look a lot harder.
Yeah.
We found this lesson in GAVA, which is a project here in South Austin. And basically the lesson was we thought, hey, let's take a zip code, let's take 2 zip codes, let's just apply everything we know, right, to community health. And turns out that when we enabled the parents and the community leaders with the right information, they were much better at pulling on the resources and getting the right outcomes for their families than just trying to deliver it to them, right?
Right. Yeah.
Kind of similar to the example you were saying, where the patient defines whether they're in a good state of health.
Exactly. Yeah. And similar to we have this notion that we can intervene on communities to improve health, just like a community is one thing, right? And which is so naive. And also that we, from the position of scientifically trained clinicians sitting in an academic medical center, we really know what's going to work on the ground in the areas that are most impacted by inequities, for example, health inequities. When the reality is people in that community know what's going to work best, and what we need to do is figure out how to enable them to bring those solutions forward, to create a platform so that success gets paid as success, and to provide whatever expertise and access they need to make them successful. So that we're trying to do that, and we're doing it actually in partnership with your foundation, and have a number of projects going on in East and South Austin.
And then the fifth lesson is, look, resources are important, but it's actually people and creativity and innovation that solve these problems. We have this really interesting customer called Aero Farms, and they figured out how to grow herbs and vegetables 390 times more efficiently than in the traditional way. Vertical farming, no sunlight, 95% less water, and they can do it anywhere. And they're using our Internet of Things technology and sensors to be able to do all this. And it's really down to creativity, and experiments, that they're able to do this and help solve a really big challenge.
Yeah, and it's similar to the notion of going to the communities to get answers. And that's definitely been part of our strategy as well. It's been about sort of clarifying what a great opportunity we have and starting from scratch here, brand new med school, Austin never having one, UT Austin never having one, this right pivot point in healthcare, and using that to say, to really draw the right people who are here to change, to make those changes happen. Tired of just talking about it wherever they were, writing about it, and Elizabeth Teisberg's a good example, writing the book with Michael Porter, Defining Healthcare Value. Tired of writing about it, now come and let's get it done. And that's been terrific. The Design Institute for Health is another good example of that. Stacy Chang heads that up. He headed the healthcare practice for IDEO, the design firm that I'm sure you guys have used through the years.
Yeah, I mean, it's really, so you're using design thinking in a healthcare context.
Right. And why are they here? It is because this is the approach we need to have. We need to start with human-centered design and really understand the problems. And they can talk about that all they want. They can design, a pill, which they were doing previously, or a new device, or they can completely redesign the healthcare system and be a part of that practice. And that's obviously a lot more exciting.
And you have attracted a rather incredible team. I think the idea of what you're building, has caught the imagination of lots of folks, and it's also really impressive to see the number of students, right, that are applying, the caliber of the students, and I'm very impressed with the backgrounds of these students, right? Yeah. So we have been, again, it's all about being able to just not rest on laurels or tradition and say, well, what does healthcare need to look like in the future? What does the physician of the future need to look like? And then also for the educational programs, what are the right tools for educating adults? I mean, these are adults, and they're not sitting in a lecture hall and listening. It's very interactive, small group work, all of that stuff. And then we want to choose our students differently as well. So yeah, we had just about 5,000 applicants for 50 slots this year, and it hurts me to go through these, and there's so many great applicants, but we're focused differently. We're looking at people who have demonstrated passion and creativity and have some evidence of leadership before they even get to us. They tend to be a little older, and it's because we're about training leaders to help to move this transformation of the health system forward. And you help to make this happen. I mean, it's also, it's becoming part of place. It's not just us, right? It's Central Health, it's the entrepreneurial community, it's the entrepreneurial community also in the nonprofit space. You mentioned GAVA, there are many others. How do we enable them? It's engaging too with the other partners, the large health systems here. Ascension has a group here called Seton, the St. David's system, which is part of HCA, is also there, and the St. David's Foundation has been great there, and how we partner with them, and in our case more with the Ascension system to move these models forward. So it's creating this sort of sense of there's some vitality, there's some potential, there's Merck moving to town, bringing the IP. This is kind of what we imagine. The biotech community, pharma, the biosciences and the computational sciences coming together. Austin's a great place to do this.
Yep, perfect. All right, good. Well, that's a good place for us, I think, to start taking questions from the audience. So again, we're using Slido, and so please feel free to submit your questions. And I guess we'll take the top one first. This one's from Taylor. As we see technology take on a bigger role in healthcare, how does this put citizens at risk with security and hacks? So we've already seen that healthcare systems are easily hacked. I mean, obviously in the UK that had a huge impact on care. So how do you see this playing out?
And you know, the healthcare record on the dark web is the most valuable one.
Wow.
And you know, we're in the business of helping to protect our customers from these threats, but you know, when it goes wrong, it goes pretty wrong, right? So, you know, somebody will present themselves, you know, and they'll say, well, you know, it says here that you know, your left leg has been removed. Well, actually, I think I have my left leg. You know, so, well, on your record it says your left. You know,
yeah.
And so you know, we do a lot to help. You know, this cat and mouse game has been going on for a long time, and it's going to keep going on. And unfortunately, the attack surface is getting much larger. I don't think the answer is don't go to the future because we're scared of the security implications. We have to take the precautions and build the security in. But let's face it, you know, a lot of healthcare organizations are pretty porous when it comes to security, right? You can sort of walk in and you know, nobody's like checking to see if you're supposed to be there, and there's, you know, USB ports all over the place and network ports, and so you know, we have to help our customers create you know, much higher levels of security in those environments. It's all doable, but it doesn't happen by itself.
Yeah, all doable. But then we also have to find systems where we can share data more readily at the same time. You know, if I show up in an emergency room today, they'll know nothing about me, and that puts me at risk. We've got to get my record to whatever emergency room I'm showing up in, just like I can use any ATM in Europe. You know, that's a lot of financial information that's being transmitted in order for me to do that, and yet we can't figure this one out for the emergency rooms. So it's going to be an interesting problem. I used to think that the financial sector was a perfect example of where we need to go, but after all the stuff recently that happened with Equifax, I think it's not. But what that future, you know, how you all help us to craft that future, I mean, it's going to be critical. Sharing data is really important for health. Okay, this is I don't know how you're going to answer this. I don't know how I'll answer it. John from Chicago asks, what are the top 3 unmet needs at the intersection of healthcare and technology? You know, it's the top 3 part that's so hard. You know, there's been a huge emphasis on sensors. I don't think sensors, I think, you know, we'll continue to see sensors evolve, but what's happened is, yes, we have sensors, but we don't know what to do with that data. So it's just adding all this data into the stream of a healthcare system that's broken. So I think how we turn, I mean, this is again an AI function, how we turn data into actionable information is critical. The problem today in the way healthcare technology is being developed is it is either being developed on the consumer side, and people who really don't have much knowledge about how the healthcare system works, or it's being developed specifically to enhance fee-for-service revenues as opposed to improve outcomes for patients. And we see a ton of those, you know, that you know, mostly electronic health records have produced ways to increase billing returns. And that's mostly what physicians are trained to do, is to document things to get more back from insurance companies, not to improve outcomes. So that's just wrong. So I think it's going to have to be, it's going to be and that's why we're so focused on get the outcomes paid for, because then everything becomes disciplined to outcomes, and then the technologies can then align around that, and it actually should liberate the technologies to address a whole host of different problems.
Yeah, I agree. Another way of stating this is to say that it's actually not a technology problem, right? The problem is that the people that are using the service aren't the ones that are paying for it.
Yeah.
Right? And so you get this misalignment, and you got to get to the value and the outcomes and ultimately cost, right? That has to be managed, and technology can aid and assist in meaningful ways. There's no question that this will be part of the solution, but there are some kind of system issues.
Yeah, definitely, absolutely. I mean, we were just talking about the fact that people don't know, they'll just go to an emergency room, any emergency room, and they don't recognize that if they go to one for that, the 2 stitches that they need on their knee because they fell, they may get a bill of $500 or a bill for $5,000, and they don't know, and that's their bill personally, not just their insurance company's bill. And that's an example. I mean, that's a need that's screaming for a solution, not a hard one, right? Just integrate it in Google Maps, or it'd be really easy to do that. And yet our system isn't aligned to make something that straightforward work. What's your view on the collaborative efforts of non-traditional healthcare players? I'm not surprised. So JP Morgan, Amazon, Berkshire Hathaway, obviously those 3 are coming together to form a new nonprofit. And I don't think they really know what they're doing based on what's it. But I'm thrilled they're
How could you not like it, right?
Yeah, how could you not like it? It's great. Apple's been trying, pushing this forward for a while. And what's their potential to improve healthcare efficiency? So what's your take on it? I mean, maybe you should talk about Apple. I'll talk about the other 3. Or why didn't you throw your name in with JP Morgan and Amazon and Berkshire Hathaway? That would have been a nice foursome.
I think I was busy that week, but but no reason why we couldn't join them. I mean, I think the idea, as I understand it, is to again get at the whole value, outcome, cost issue. And so I don't think they would have any problem getting other large companies to join up with them if they actually come up with something interesting.
Right?
And so I think it's great if folks want to go off and try to innovate and come up with ways of addressing the challenges. There isn't going to be one answer here. So
too difficult, too big. Yeah, there won't be. Yeah, I agree. I hope it works. I'm excited about it. But I think the way we're approaching it is that it's too big a problem to just say, okay, we're addressing this problem, right? And we've seen entities that have been designed to do that. So I think Kaiser Permanente is a good example. Intermountain West is not. So they own everything, right? So they can control all the costs and outcomes. They can compete based on outcomes, and they have created better systems, but they're not dramatically better. They're not dramatically cheaper. They don't produce dramatically better outcomes. So we're not there yet. They don't innovate, I don't think, quickly enough. So what we've tried to say is it's not, yes, that is the entire system, but the entire system is incredibly difficult. The conditions are so different within healthcare. If we require that innovation just happens for the entire system, then only a few innovations can come down. I mean, the UK National Health System is a good example of that as well. But if we say it's not that, it's a series of individual conditions and products, each of which could be improved on its own and then integrated into a larger system, then you actually have bucketable problems where products can compete and develop and hopefully get disseminated. And so that's why that joint pain one is a good example. Then, diabetes care, bipolar, depression, back pain. We've got a bunch that we're developing, primary care being part of that as well. But it makes it into something that one can address. And then those become the products for these guys that are going to be integrators, like Amazon, or you all, right? As a consumer of healthcare.
Yeah, I think what's interesting about the individual consumer in the context of healthcare is that the answer seems to me increasingly has to be the consumer is going to pull on the solution instead of it being pushed to them. So as you go to value, outcomes, cost, it's going to be, hey, I'm more responsible for my behaviors than I was before.
Yeah.
I can't just blame it on somebody else and, well, it's all their fault. I take this pill and,
Totally agree.
Hey, I'm just doing what it says to do over here. And,
right.
It has to be more responsibility in the system. And that's where I think the sensors and the information, the devices can actually be helpful. And you got to imagine a world where it's 2020 or 2025. Somebody turns 20 years old and they say, hey, this is what is going on in your body, right?
Right.
Genetically, right?
Yeah.
And by the way, you're kind of predisposed to this and that and the other thing, and you might want to. It's like you got a new house, right? And here's how you take care of your lawn, and here's how you maintain. And how do you have a healthy, full life without these chronic conditions?
Yeah.
And I don't think it's like solving the mysteries of the universe, right? With some of the conditions that are out there today.
Oh no, that's pretty clear.
so
if you want to get rid of your diabetes, what you should do about it.
Exactly, and so how do we get the individual consumer more information, more knowledge, so they're actually driving it? That has to be part of the answer.
Yeah, I agree. I think it's empowering individuals to take more charge of their health. And that does actually mean empowering them also to understand the decisions they make about how they access healthcare. Of course, today they can't even know cost. It's not clear. No one shares that, or outcomes in the individual.
And look, we know in our context as an employer, there's certain people who access the healthcare system like 5 or 10 or 15 times more than others.
Yep.
Right. And in many cases, they're these kind of behavior-based conditions that end up being very, very bad, right, and expensive.
Right. Yeah. Good. All right. So the next question actually relates to that. So access of electronic health records digitally. This is one of the things that Apple's been working on. You remember Google Health did this like a decade ago. It didn't actually work.
And Microsoft has
and
tried
Microsoft
this
same.
as well.
Yep. And that maybe they were just before their time. The uptake wasn't there, and also it required a lot of maintenance from individuals to post their data, to request it and get it in it. And obviously, one could force you as an individual should own your health records, and then you should be able to call it into a central repository that then you could direct to emergency rooms. So, my bias is that this should happen. That we should put us as individuals at the center of the health record. But how do you see that rolling out? I mean, is this time gonna work with Apple's new approach, or?
There have been several attempts at it. It makes perfectly logical sense. I mean, I think there are vendors that will sort of fight against that, for one reason or another. But it's interesting that it really hasn't occurred yet,
right.
At least on a broad scale. I know we at Dell have efforts to make that information available to our people, and let them use it in the manner in which they choose. But you think more progress would have been made there.
Right. Yeah, I agree. All right. This probably is our last question. We'll have to answer it quickly. So where should healthcare systems start with AI? Clinical areas or operational areas? So where should they versus where will they or have they? So, I mean, AI is also is used to figure out whether you can possibly increase your coding return on patients by reviewing electronic health records. That's one of the initial uses of AI. And I hope, my hope and should is that we get away from trying to milk more dollars out of a fee-for-service system and really push AI to address efficiency and quality issues, in particular quality issues. I do think it's going to be natural for AI to do more and more of what radiologists and pathologists do, but I think there'll be resistance to that in the healthcare system, and it'll be interesting to see. I don't think the healthcare system will allow that to pull dollars out of the system. The efficiencies will not be realized the way they could. But for workflow, for understanding risk factors, identifying people at risk, just as you described in Dell, and then being able to intervene on them to improve outcomes, reduce costs, I think that's going to happen.
Yeah, and you know, we as many employers do have these systems where, you know, if we see somebody, actually not we, but we have a third party that does it, see somebody going down the path of using, you know, a lot of healthcare services more than normal, we can kind of detect that they're, you know, going in a bad way. Third party will contact them and say, hey, you know, how about some lifestyle help here to you know, avoid these conditions? And, you know, a significant percentage, majority of people will very much welcome that. So I think using technology to provide, you know, to help people with better outcomes and healthier lives, I think that's the promise here, and, you know, no better place to have it start than here in Austin at Dell Medical School. Yep,
and Dell Computers. Well, thank you. This has been a pleasure. Great spending this hour with you.
Absolutely. Thank you. Great.